So my question is this. So here we are as scientists, and we're all talking to ourselves and enjoying this day. My question is, how do we get the people outside to know this information? You know, we all are very lucky to be involved in the scientific community where we know that adipokines are sending all kinds of signals to our brain and maybe altering our reproductive capacities, and all kinds of things are happening. So how do we get this information to the public is really my question.
Let me take this one very quickly. Not that I do have an answer, as I'm not specialized in communications, and I do agree that we need to do a better job in communicating what we do. And to that end, this public symposium was one of the ideas, although we obviously planned it in a bit of a midterm going on here. So, but I think it's a very good point. Communication is tremendously important. So I would let others to chime in.
I would say I don't think it's enough to get the information to the broader public. It's doing it in a way that it's believable and believed. Even the effects of smoking on lung cancer and heart disease are not believed by a sizable fraction of our populace still, which is amazing. But I think in diet, physical activity area, having more definitive data than we do now on the whole range of health risks and benefits is an important feature. We have guidelines from various august agencies, which are generally very sensible, but I don't think they have the force that's needed to really impact the food chain and the way cities are designed, and decisions about supplementing or fortifying the food that's available to us, or address the economic impacts, especially in poorer neighborhoods where the better quality food isn't available, and so on. So I think it's really a lot of societal issues tied up there that we have to work on in a multidisciplinary way. Thanks.
It's a wonderful question, and I'm concerned that the problem isn't information or the quality of science, or even people knowing, but it's the opportunity costs and the manners in which individual people or the community takes action on. Because there's a big opportunity. There's choices each day, and people have to decide what they're going to do for their leisure time, whether they have leisure time, and though we're not equipped as scientists to have a strong impact on that, there's people that are sophisticated because of their position or because of their training in the part that touches the science, and maybe that's where we need to work harder. We need to make some link there. I was fascinated with the idea about who will benefit from the consequences of even these fascinating polemical discussions like the one we just had, and for them to make a difference, we have to think up campus with our friends in law and sociology and the like, but also perhaps even more so with the people engaged in the community.
If I could just add, as we're getting to the next question, I think doing our part as scientists and as community members to resist advertisements aimed, for example, at kids that really get dietary habits off in the wrong foot at an early stage, or making sure we get the pop machines out of the schools in prominent places. Quite a lot of that is happening, but I see it as a pretty similar problem to trying to rid ourselves of tobacco product exposure. A lot of the same forces are at work.
I'd just like to add to what the panel and to your question. My name is Ali Izzat Penna. I'm part of Dr. Roberts and Dr. Barnard's lab. I think that we should work with various organizations on the national level and state level to get this message of diet and exercise, especially out to the younger population, to children. My sister is a medical student at UC Davis, and a couple of weeks ago we attended the CMA House of Delegates, the California Medical Association House of Delegates meeting. They have an annual meeting where they propose resolutions. She proposed 2 resolutions. One was to change nutrition labels and how they manipulate values to make products seem to have no trans fats, whereas they do have a significant amount. But more importantly, to answer this question, she also proposed a resolution to increase physical activity and required physical activity in elementary school students and middle school and high school students. I believe the current requirement is about 20 minutes for elementary. She proposed a 10-minute increase per day for elementary school students and even more for middle school and high school students. And this proposal was passed. And so CMA is now pursuing that to change that in California, and hopefully also work on a national level to adopt those recommendations which were recommendations by the CDC. So I think if we can use your research studies to convince other organizations that can reach out to the public, it's one thing we can do.
I was just wondering if there was any correlation between bone density and insulin resistance.
Yeah, I think there is. Remember, Tom, we did these studies together. I mean, there's certainly a correlation between lipids, blood lipids, and bone density. And you know this better than I do, Tom.
It's only from literature reviews from a couple years back, but my recollection is it's complex because insulin itself can act as a positive factor in increasing bone density, but then at the same time you get increased insulin due to insulin resistance syndromes, and so it was a mixed bag in things. So sometimes heavier people had better bone density, but they weren't necessarily healthy because of it. So.
Yeah, I was just wondering if that would play into the lean body mass theory, because I know with an increase in lean body mass, you get an increase in bone density. So.
In inflammatory bowel disease, there's been a big study about bone density and that chronic inflammatory state. And there is separate from that's a bit complex because there can be malabsorption problems in that disease, but as it's been modeled out in people as well as in mice, that there's I guess you call it an inflammatory cytokine input into the bone metabolism. And so, since I think we're all thinking of adiposity reflecting it becomes an inflammatory cytokine organ, that I guess there's a link there to be made, but I don't have the link myself.
I'll mention two things real quick. Number one is that Dr. Barnard, in collaboration with Ron Zernike, when he was here at UCLA, basically showed that when animals were fed a diet high in fat and sugar, they actually had a decrease in bone density. And I also want to mention that in my current trial, where we're giving resistance training to overweight young men, we're doing DEXAs, and so one of the outcomes that we're looking at is bone density to see whether or not, if the subjects improve their insulin sensitivity, is that related or not to their bone density.
So I think in academic research, we're always focused on how things work. But in 100 years from now, once we figure out all the gene and environment interactions and diet and exercise, once we figure all that out, it's going to be a very complex story for the public. So where do you guys see, with our knowledge in 100 years, where do you guys see, from this public standpoint, what should they take home at the end? Should they all learn about all these complex diseases, or like, I have to eat this X in the context of Y, and I have to exercise, and only if I'm African American? Or are we just waiting for a pill for every single disease?
Probably neither of the above. So I think the ultimate goal is probably more in the administrative side or legislative side that would improve the food supply and improve the city design and make it easy for people to have better dietary habits and better activity patterns, as opposed to a lot of prescription that would be confusing and wouldn't be followed anyway. So I think that's it. It's attractive to get into the personalized prevention as well as personalized medicine, but I think especially on the prevention side, our goal has to be keep it simple and have ultimately lifestyle recommendations that can be applied and that can be adopted to be successful in these areas. A lot of it's returning to patterns that we used to have decades ago and other parts of the world still have, so we know they're practical under some environments. We've gotten away from those, got to take back some control, I think, more control of what gets into the food supply, how the various types of products are developed. And I think city planning is really difficult. LA is a big freeway, right? But European cities have a lot we can learn from in the way that they're designed with the central square and encouraging walking and so on. So it's bound to take a while, but I see those as where we should ultimately be aiming.
I'd add two things. One is that I think it's a bit like a car. You know, maybe it's not so good we're driving cars, but many of us do. And that's the product of a fantastic amount of technology, in engineering that most of us don't understand, but it's designed so well that we just get in and use it. And so what would that mean in terms of, what would be the equivalent of that car, that turnkey thing? I guess one would be that our policies right now are designed, the food chain and the like, is designed for best economic output measured by certain things. And the econometrics that we use for society don't capture the impact of this on the productivity of our society. And so that's where the sociology and the policy and the like could come around. Because, for example, I can imagine that when we have a proper econometrics, then we would be able to you might say, reward people for lifestyle things, so that what they have to pay for the universal insurance we all will have to carry shortly, God willing, that you'll have a lower premium because you're making certain choices. You don't have to wait 30 years to see if that gives you less health. But instead, right up front, you get the financial input from that. And in our society, which unfortunately is presently organized in that manner, that might help us. Second would be biomarkers. If you had some simple biomarkers which reflect these different sorts of things, so that there'd be a simple way to read that out. So day by day, rather than getting on the scale, you would get the sort of input, and then you'd get some immediate feedback to say, like, I did my 10 reps times 3, and now the biomarkers look good. I think for a lot of people that will help, and also allow them to make better choices. So I'd say biomarkers and a policy which captures, in a way that's economically driven, these choices.
Sort of related to that, in 100 years, I'm sure we're all going to have our genome sequences, right? So we'll probably have little CDs with our genome sequences, and you can go in there and see what you're susceptible to, or so on, and that might, direct you towards certain things. If you know you're, susceptible to heart disease, maybe you would take additional. Well, it's the same concept as biomarkers.
Brian, as you asked this question, there are two quotes that flash to mind. Number one is by a great German pathologist, Virchow, who said, disease is ultimately a disturbance of human culture. When he said that, he was referring to the English threat at the time was the epidemics. Then soon after he said that, cardiovascular disease emerged as mankind's #1 killers of the 20th century. And now, obviously, the reason why we have this symposium is that metabolic disease, such as obesity and diabetes, emerge as yet perhaps mankind's #1 killer of the 21st century. Now, anyway, estimate by WHO and several authoritative bodies anywhere between $1 billion people is already overweight or obese. 250 million to 300 million with type 2 diabetes. This is the current figure, okay? So you can see at this point in time that we are facing these issues. So society is going to have to collectively decide what would be the cost to take for prevention purpose. And I've been thinking about this for a long time, primarily because I'm in the public health school now. And I come to this conclusion, ultimately, it's actually quite paradoxical. What we can do in public health ultimately can only be achieved individually, precisely because we live in a democratic society. That said, to answer you another question about science, another quote, "Science is the endless frontier." There would always be things to study. 100 years ago, someone out there may have asked the same questions you asked. 100 years from now, you figure out all this English threat, all this infectious disease, etiologies. But look what's happening right now. And so I can guarantee 100 years from now, there will be disease of future culture, okay, that's plaguing us, that need smart people like you, your descendants to answer those questions.
And if I could just add, I mean, Dr. Liu stole my thunder, but definitely 100 years from now, there will be a whole new host of diseases. We don't even know what they are now that we'll be worrying about. Just like 50 years ago, we were worrying about different diseases that we're worrying about now. Two other quick points. Number one is, again, because we'll know the genome, maybe we will be able to individualize all these things better, individualize prescription, individualize medicine. And then thirdly, one thing that I've noticed in talking to some of my colleagues is that a lot of times things don't get done, and this goes back to what Dr. Braun was saying, things don't get done unless there's policy changes made. I mean, you can do, 100 studies that show that when, guys who don't wear motorcycle helmets have increased risk of head injuries or death, and they don't do anything, but once there's a law saying that someone has to wear a motorcycle helmet, then it goes into place, or someone has to wear a seatbelt. So if we have a law that says that we have to eat a low glycemic load, then maybe that will have a dramatic impact on obesity, diabetes, and heart disease. Or if we add a sugar tax, like someone was alluding to before in one of the questions that people were asking.
Okay, I'm May Wang from the School of Public Health. And I just want to say thank you for organizing the symposium. I haven't had a chance to sit through all of them, but the ones that I've sat through have been enlightening. And it's great to kind of see the combination of scientists from basic to more intervention research. And one of the comments I want to make is, actually, Dr. Roberts just mentioned it, the importance of policy. I think, a lot of these diseases affect the poor disproportionately, particularly in this country. And what's been alarming to me, having been in developing countries recently, is just to see this rise in chronic diseases that parallels the undernutrition and the infectious diseases at the same time. So I'm not sure what the solution is. I do know in terms of training, in public health, what we're trying so hard now is to get our students to become more interdisciplinary, so that they're able to at least bring people of all the different disciplines together. And that's the one thing I actually had my initial training in the lab running assays. I've kind of gone way to the other end, kind of really have my foot in the community now. And I realize the way we train ourselves to think about things is sometimes a little bit different. So, I'm no longer as comfortable talking to people in the lab today just because I've kind of lost track of a lot of the new terminology in genetics. At the same time, I see a lot of my colleagues in the lab having a hard time, with terminology, having an intellectual conversation with a social scientist, for example. So, and even in terms of inductive and deductive reasoning, the paradigms are just different. You talk to an anthropologist, they don't have hypotheses. So if you ask them, what sort of research are you doing? What's your hypotheses? They won't know how to answer because some of them are not trained that way. So I'm not sure what the answer is. I do know that it is kind of important that we try to bring scientists from all the basic and the social sciences together.
Go ahead.
following up with the talk on policy, and related to what Dr. Prentice had mentioned, he said that a lot of our disease prevention will probably come from going back to the old ways of living. And do you guys wonder that tampering with policy sometimes leads to some of the situations that we're at right now? And I think you guys alluded to that as well. Like, there's going to be new diseases in the future that we haven't seen before. And do you guys think that it's possibly dangerous, that it's policy related?
I'm not sure if you're saying like the law of unintended consequences. I think he's had to leave, but I wouldn't take. I don't think it's a wise idea to make choices based on the idea that what preceded us was better. I mean, what's probably correct is that something that we've done could create a problem which we try and understand and fix. But like 50 or 100 years from now, people would say, boy, we have to live like they were living in 2010 because that's when everything was nice and they didn't have the problems which we now have. So I hope that sort of captures the idea that I don't think it's correct to say that the old days were good. In fact, there's beautiful history about primitivism as being a recurrent social approach that communities will take, and that it's a misguided way to frame things. It probably is correct that the nutrients that we're having now and the way that we take them in isn't well melded to our physiology. And so I think that's why maybe if we can create tools as scientists, bring them to policymakers so that then we can have biologically organized ways to try and keep people out of harm's way. That's the way I would frame it.
Yeah, I also wanted to follow up on what John was referring to about opportunity cost. 10 years ago, when I presented WHO map of diabetes across the world, they listed the diabetes prevalence then in 2000, and then they have a projection figure to 2010. So I often would ask questions looking at that map and say, look, if you guys pick where is the safest place to live, so you will have the lowest risk of developing type 2 diabetes for the next 10 years, where would you choose to live? The answer was back then was in the United States. The United States of America is actually the safest place judged by that projection of future risk for the next 10 years. And now the worst place to live in terms of developing the risk of diabetes is India and China. The second worst place to live is in Africa. Just speaking of diabetes, still United States of America is the safest place to live.
Safer than Europe?
Yeah, slightly safer.
Surprises me.
So then there's an opportunity cost here. Well, I mean, we don't live in a society that we only focus on lowering our risk of developing type 2 diabetes. So the way I see this as scientists or intellectual thinkers, we should analyze the situation and present it to a society such as ourselves, which is a democratic one. Then somehow, collectively, we need to make those decisions, right? I mean, like there's opportunities cost. If you want to live a long life, then you need to do X, Y, and Z. Or if you do a high quality of life, you need to do X, Y, and Z. Basically, those are the simple questions that I see as scientists. That's what we need to do. But what I actually want to ask a question, John just walked out, although I see Dean's is coming back into. So I wanted to ask this question is directly related to our own UCLA structures. There's no doubt in my mind this kind of interdisciplinary trainings are necessary. And something for the future generations of scientists where you can truly capable of basically at home, as May was referring to, when you hang out with the laboratory-based scientists, or even all the way to quantitative population-based scientists, or even the policymakers, that you can talk the talk and walk the walk. So to interact with them and truly exert some influence. But the challenge is also there, and how can we achieve that kind of training to not to become, a job of many trades, a master of none, especially at the junior level of your development, at the beginning level. And that's something that I've been scratching my head as an educator to think how we can mentor you to be able to do those things. And then also excel through the system. And I would like the people who are experienced, maybe Tom, you have been involved in the educational system and the medical side here at UCLA for a long time. Would you mind commenting on that in terms?
At a direct level, that's mostly been medical students, and it's a different issue, I think, in there, because there the sequence is really prescribed, and so I think I'll let Dr. Robinson answer that. But I was just going to make a comment that one of the common themes that I think you heard in almost every talk was the use of mathematics and analysis. And I think certainly in my personal experience in working with Jake and others, that you don't have to be a mathematician, and you probably are wrong to try to be the mathematician, but you certainly need to get to a point where you're comfortable interacting and understanding when people are talking with you.
Well, I think that one of the key things for this that students should get out of this is that being interdisciplinary does not mean lack of excellence. I mean, the worst thing you could do is be so thin in things that you really don't see yourself as expert. You can be an expert in community engagement, and you can be at the top of your game there. You can be an expert in laboratory science. In any of those, this program proposes to give you enough experience in all areas that you can talk to everybody, just as you heard a couple of minutes ago. But I would just caution, if you want to really succeed, and certainly if you want to succeed in academic medicine, that you don't give up the idea of being really excellent at what you do, because that is absolutely critical, and I think that will be recognized in any career.
Thank you, Alan. Thank you for stepping up as some of our speakers are leaving.
So I'd like to make a comment on this point. So I'm a quantitative scientist, and I think one of the real challenges here is that I would say that probably the bulk of the people who are interested in this kind of interdisciplinary training come from more biological background, and what they're trying to learn is more like the quantitative computational side. And I think one of the real challenges here at UCLA is that even to obtain a basic kind of strength in computation, I mean, even just to be able to manipulate data sets and things like that, requires actually a lot of time. Students should learn how to program. If they've never done that, that takes a lot of time. There's a lot of statistics, even just to understand the methods, not develop necessarily methods. And I think one of the real challenges here is that a lot of the, PhD programs in the school are very, they don't have a lot of flexibility for students to be able to invest this much time. And PIs are putting pressure on students to, do research right away. So I think that, we should really consider how we would do this. I mean, it would take a really exceptional student to be able to, achieve excellence in the PhD program that they're in, and also invest in like a year or two of additional coursework outside of their field. So I think that we should be realistic. We should, think that, okay, well, maybe we should expect interdisciplinary students to take a little bit longer, you know, or maybe if there is some, you know, kind of breadth requirements in the PhD program that are not central, maybe some of those would be, you know, the flexibility so they could take maybe computational classes. I think there's really some kind of structural issues that need to be addressed in order to make it kind of possible for students that are interested to be able to do these things.
It's a very good point.
Two things about that. First of all, you're absolutely right, and we struggle with this all the time. We're right now thinking about how to reorganize some of our graduate student programs because I don't think that we are interdisciplinary enough. But I would say that when you talk about the kind of education that you get as a student, the other thing to remember is it doesn't stop there, that you continue to get education throughout your career. So there will be things that you didn't learn about. I can tell you, I started this job about 14 and a half years ago. I came out of a laboratory. I came out of a clinical background in clinical research. And I came into an environment where I was expected to oversee education. And I had never spent very much time in education. And people were talking about adult learning theory, computer-assisted education, active learning. And I guess I sort of knew what those things were, but not in any kind of depth. So what do? You retrain yourself. You know, you start a journal club. You start reading. You start talking to people. You go to lectures. So there is the way to keep learning. And you won't get everything out of your student days. You just won't. There's too darn much there. But if you come out with the right attitude and just keep learning every day, you can pick up those things, and you can pick up even very basic scientific things. I have empathy with the people who are involved in quantitative aspects of handling data, because that's a real skill set that very few of you, and certainly not me, will ever learn. I'm just going to have to learn the vocabulary and let somebody else be the expert.
Thank you, Alan. I think this is, you're speaking to the highest level of medical leadership here on campus. The way that I can tell you that with the support that we have consulted literally all the department chairs when Tom and I trying to put this program together in response to this RFA from Welcome Funds. The way we see this is, number one, we need to instill in our students a lifelong self-learning or self-guided learning habits. That's extremely important, as Alan alluded to. But from a mentoring perspective, what we can do is to create that culture. And now we have the highest support in the medical school as well as the School of Public Health, which specifically related to this metabolic disease program. We actually get some idea from the computing or programming community is to develop so-called object-oriented programming with the focus on metabolic disease as the central focus of learning and teaching. We're keenly aware of both sides of the camps. We can talk to a lab person who can say the same thing, that the laboratory training is extremely arduous, much more difficult than the quantitative. You can just massage the data and something come up. Whether you go through a knockout model, different kind of laboratory process. And I think both need to develop the appreciation and understanding of each other's works, and that would, in fact, would be the best to come together to really tackle those difficult issues. And ultimately, like I lay out a benchmark. The benchmark is to lower the burden of those diseases of our focus here. Now, to do that, we also specifically identify a common set of some core courses for people from different backgrounds to take. And most departmental, we also recognizing that if we truly develop a brand new PhD program or so-called interdisciplinary program that had to go through UC approval, we probably have to graduate our very first PhDs in our program, from our programs 10 or 20 years from now. So we recognizing those existing bureaucratic structures. The way we pursue this is that we will, within the existing departmental structure, trying to build in a minor. For example, for someone coming from a quantitative background, in fact, UCLA is very strong with so many departments, Department of Statistics, Department of Human Genetics, Department of Biomathematics across campus. They can sign up for courses that fulfill their minors or second fields where we consider as major in some of the more biomedical-oriented or laboratory-oriented disciplines. And then with also, hopefully, with the, well, our initial list of key faculty member on this program is also fairly selective. And we did it on purpose so that, you know, we will really have someone who sign up, really truly can contribute and sign up. And then the program would be small. From the beginning, we plan to have 2 or 3 students and gradually grow and identify mentors that would have different but complementary experience to help co-guide the specific students.
There'll be any place for the fellowships to be given also to some of the clinical persons. The advantage of that, as you know, is when you have people from multi-specialties, sometimes the clinical people may be able to bring, trainees may be able to bring a different perspective, which would help the overall goals. And the second thing is in some specialties, and I can tell for our specialty of obstetrics and gynecology, there are very few really good molecular epidemiologists like you are. And that is a part which we are deficient, and I hope this program will help train those people as well.
Thank you, Dr. Sandri. We are supposed to discuss all this issue in our advisory and steering committee meetings. Not sure we should discuss this in a recorded manner, but those are very good ideas. I mean, we all have inputs to, so we can shape the program any thing that we see fit. Ultimately, developing, again, the next generations of super scientists who have the ambition and capable of dealing with this, what we see truly is a major epidemic.
The Burroughs Wellcome Fund does have some restrictions about what kind of a program that we can support for that. It's primarily geared for a PhD, and I believe we got information that it could be applied to a master's kind of a situation, which might fit what you're talking about, but it would not be applicable to just a general, quote, fellowship or postdoctoral type of experience.
Yeah, that's true.
So,
but we do want to explore whether or not we should build into like the STAR program, the existing program, the medical school, as well as the more across the campus access type of program where we identify students to give them the appropriate support.